A 54-year-old woman with a history of cholelithiasis and jaundice underwent ERCP with sphincterotomy, where two stones thought to have been causing obstructions were removed. During the post-op period, she began to suffer from severe epigastric pain. We need to see her management. Her labs are she has high creatinine, high amylase, elevated ALT and ALP, but ALP a lot more, and high bilirubin. So I guess what happened, does she have a fever? No, she just has pain. I think she has pancreatitis. The management, well, IV fluids and analgesia, but then yeah, I don't know what else we could do really. Yeah. In the first instance, this woman has developed pancreatitis. Post ERCP pancreatitis should be managed medically with IV rehydration, analgesia, and antibiotics. ERCP is probably the third most common cause of pancreatitis after alcohol and gallstones. It might be related to inadequate hydration at the time of procedure. Okay. Next question. So we have a 48-year-old woman with chronic hep C, comes for review. She's been diagnosed with mixed cryoglobulinemia. What would be an unusual finding? Livedo reticularis, positive rheumatoid factor, palpable purpura, severe pulmonary fibrosis, glomerulonephritis. I feel like mixed cryoglobulinemia. Is it severe pulmonary fibrosis? I'm just gonna choose that. Yeah. A restriction in FEV is associated, but severe is rarely seen. That makes sense, actually. Okay, so we have a 31-year-old woman. She's 33 weeks pregnant with her first child. She came to the ED complaining of a severe headache with easy bruising. She has a high blood pressure. Her only medication was Gaviscon, which she had been given a few weeks ago by her GP for indigestion. Her labs, she has a very low platelet count. This is, I'm guessing this is HELP syndrome. The management is going to be magnesium sulfate, I guess. Yeah. So this is HELP syndrome. It's a severe variant of preeclampsia. It carries a high risk of progression to eclampsia. A lot of people picked DEXA. This is not the appropriate initial management in this case. They may be administered antenatally to promote fetal lung maturation, but it's a secondary obstetric consideration rather than an immediate maternal intervention. There is no convincing evidence. Okay. Most suggestive of a pyogenic liver abscess rather than an amoebic liver abscess. History of recent biliary colic and fever. Patient age over 60. Elevated white cell count. 2-month history of weight loss and diarrhea. Solitary abscess in the right lobe of the liver. Which one is most suggestive of a pyogenic and not an amoebic? I don't think it's age over 60. Biliary colic? How is that relevant? I don't know. Fever, yes, but I think it's also 2-month history. Diarrhea. Solitary abscess. I have a feeling it's solitary. Do I have a strong feeling to exclude something else? I do think that both are going to have a high white blood cell count, so I feel like I can't pick this, and I also can't pick B. So A or D. A history of recent biliary colic and fever. I don't know. 2-month history of weight loss and diarrhea. I don't think this is right. Don't know why, it just feels like no. Biliary colic, solitary abscess in the right lobe. Why is it not? Okay, I'm gonna pick this. Yeah. So it's in developed countries, pyogenic liver abscess usually occurs as a complication of pre-existing biliary and GI inflammation, usually bacterial disease. The usual cause of pyogenic liver abscess is enteric flora through staph, although Staph aureus is a well-recognized cause. Recent biliary colic and fever raises the possibility of pyogenic liver abscess occurring as a complication of cholecystitis. The other one that I was confused about is solitary abscess. So both sorts of abscesses are usually detectable on ultrasound, but often have different appearances. Pyogenic disease often manifests with multiple liver abscess. So a solitary abscess in the right lobe of the liver is much more typical of amoebic disease. Regarding the weight loss, pyogenic abscess usually presents clinically with a systemic febrile illness lasting from days to weeks. However, amoebic liver abscess typically has a more indolent course and has weight loss and diarrhea. That makes sense, actually. So yeah. A 58-year-old man complains of tiredness, fever, weight loss, arthralgia, diarrhea, jejunal biopsy. This is Whipple disease. Yeah, it's not topical sprue because topical sprue is going to have shortened villi, elongated crypts, and a collection of different inflammatory cells. I don't know why it's a secret. You could just tell me what they are. Anyways, a kind reminder to myself that I'm doing the easy to average questions, so stay humble. A 34-year-old woman is admitted with increasing tiredness and lethargy over the past few weeks. She delivered twins a year ago. She has a previous history of IBS, although her GP never sent her to investigate this. Her blood pressure is fine, pulse is fine. She has a number of mouth ulcers. Is that celiac? Maybe. Yeah, I think it's celiac actually. I'm going to do anti-TTG. I would do anti-parietal cell antibodies if I'm suspecting pernicious anemia. I would do a colonoscopy if I'm suspecting colon cancer, I guess. I would do a fecal elastase if I'm suspecting pancreatic insufficiency. So that's the answer I'm picking. I mean, she does have a vitamin B12 deficiency, but she has a low ferritin and IDA, and these are both. I mean, we don't know if it's immune deficiency, but she has anemia, and these are both associated with celiac. Okay. So we have a 42-year-old math teacher was living in Trinidad for 15 years and then returned to the UK. She has a 3-year history of intermittent diarrhea, steatorrhea, weight loss, cramps in her calves, and marked lethargy. So we did some tests. She has hypocalcemia. She has hypoalbuminemia. Also, she has macrocytic anemia. She has an inflammatory cell infiltrate of lymphocytes, plasma cells, and eosinophils. Is it going to be celiac, Crohn's, Giardia, tropical sprue, and Whipple's disease? I have a feeling it's tropical sprue, just because of the jejunal biopsy findings. It's not celiac. Yes, it's tropical sprue. The jejunal biopsy can be abnormal in all the conditions listed, but it is the combination of the time in the tropics, malabsorption, and the resulting deficits, plus the acute inflammatory epithelial infiltrate, that makes tropical sprue the diagnosis. Tropical sprue is mostly seen in residents or long-stay travelers in southern and southeast Asia, the Caribbean, and Central South America. Diagnosis requires demonstration of partial villus atrophy, exclusion of other causes of diarrhea, and the presence of fat and B12 malabsorption. Hypocalcemia may also be a feature. A lot of people picked Whipple. It's not Whipple because There are no other features to support Whipple. There's no migratory seronegative large joint arthropathy, there's no skin pigmentation, finger clubbing, and fever. And also, the biopsy would show foamy macrophages with which stain positive for PAS stain. Okay, we have a 27-year-old man. He works as a bond trader. He comes to the ED complaining of recurrent abdominal pain and bloody diarrhea. He has griping pains in his lower abdomen and passes bloody diarrhea 5 to 6 times a day. Okay, he's not had any weight loss. He's a smoker. He drinks occasional alcohol and uses cocaine 4 to 5 times per week. He didn't travel. His blood pressure's, I don't know. It's a little high, I guess. Pulse is high. His BMI is 25. There's left-sided tenderness on palpation. His fecal calprotectin is borderline, and you want me to diagnose this boy? Well, he has bloody diarrhea. That's the only thing I've gotten. And a left-sided pains. So what else does he have? His ESR and CRP are kind of high. I don't think this is IBS. IBS wouldn't cause bloody diarrhea. And it's not infective. There's no infective proof of any infection. So is it Crohn's? Is it ischemic colitis? Is it ulcerative colitis? I don't think it's ischemic colitis. It's a young man. He doesn't have any risk factors for that. So it's either Crohn's or ulcerative colitis. So which one is it? Because he has left-sided tenderness on palpation, I'm going to say it's ulcerative colitis. Yeah, that's what I'm gonna say. I don't know. Oh, damn. Why? He uses cocaine. That's why. Cocaine is a potent vasoconstrictor and can cause mesenteric vasospasm, leading to transient colonic ischemia. So it's not ulcerative colitis. Why? Because the ulcerative colitis would be associated with a clearly raised fecal calprotectin, and the patient would develop anemia due to chronic blood loss. This is not chronic, is it? He has left-sided abdominal pain, which fits involvement of watershed area. Wow, interesting. So, ischemic colitis can be caused by cocaine use. So if you have a younger patient who uses cocaine 5 to 6 times a week, that's kind of a lot. Okay. So we have a 72-year-old man, and he has a 3-year history of severe abdominal discomfort and vomiting that occurs 30 minutes after a meal. He has arthritis, heart failure, peptic ulcer. He's been well, although has gradually lost weight for the past 1 to 2 years. His blood pressure is high. Everything else is fine. So he has a significantly slowed gastric emptying. Why is that? I really don't know why. Why? I don't get it. I know it's the treatment. 3 years of severe abdominal discomfort and vomiting. Severe. What's the issue here? I don't know. Severe abdominal pain, discomfort, and vomiting. And why is the gastric emptying scintigraphy slowed? I don't think dietary advice is enough for this boy. Surgery? I don't think so. I don't think it's in metronidazole either. Endoscopic dilatation or cyclizine. I don't remember what cyclizine was used for. It was used for a nausea and vomiting that was caused by high intracranial pressure. It's an antihistaminic. It was also in vertigo. Okay. I'm gonna pick. But I don't think it's. Oh, I'm so confused. I don't know. Why is it not surgery? Why would it be surgery, Aslan? Why is his gastric emptying slowed? You know what? I'm going to do this thing where I take a screenshot and I go on Gemini and I tell Gemini, give me a hint without revealing the answer to this question. And then I use the guided learning tool. I feel like it's going to be something like really simple and let's break this down. To choose the appropriate therapy, we first need to connect the patient's history to the objective results. Investigation highlighted gastric emptying scintigraphy is the key. It shows the stomach is emptying much slower than normal. This rules out conditions characterized by rapid emptying. The patient had surgery for peptic ulcer. Historically, these surgeries often involve a vagotomy. Maybe so he doesn't have enough acid production. Oh. What is the medical term for this state of stomach paralysis? So some sort of nerve damage happened. Well, yeah, okay, but what would be the answer? What is the medical term? Come on, just be faster. Chloride? That's the only thing I could think of. It's not in the options. So we need a prokinetic drug. Can I just pick cyclizine? Is it a prokinetic? Oh my god. There is. I only see metronidazole. Is it metronidazole? That would be crazy. This is kind of a difficult question, is it not? Or am I just overthinking it? You know what? I'm just gonna pick this. That's insane. That was what I'm going to pick. So this guy has got chronic GOO as a result of scarring and fibrosis. It is thought that up to 75% or more of patients may gain relief from anoscopic dilatation, although those who do not, of course, often progress to surgery. That's insane. But I would have picked this if I didn't use Gemini. So maybe trust yourself a bit more, honey. A 31-year-old man, a patient who had previously quiescent ileal Crohn's, has had two relapses in the last 12 months that necessitated hospital admission. He is now feeling relatively well and denies any abdominal pain, diarrhea, or weight loss. His MRI small bowel has not demonstrated any strictures or fistula. What treatment option should now be considered? Is it not azathioprine? That would be crazy if it's not. Okay. So it should be started if the patient has more than one relapse in the last 12 months. An obese woman attends your clinic asking for dietary advice, but unfortunately the dietitian is unavailable. Which of the following has the most calories per gram of weight? It's whatever has fat. So, not pasta, not white bread, not sugar, hard cheese, or a lean red meat. I think it's hard cheese. It's not. It's not going to be a lean red meat. It's definitely whatever's got in the fat. So, 28. She comes for advice, and her BMI is 39, and she's always been overweight with a consistency to gain weight through her life. Consistency to gain weight. That's not even, is that a word? Anyways, her mother is also significantly overweight, as her two sisters. She wants to know why. The most important causative factor. Leptin deficiency. I think yes, because if it's genetic, it would be like if it's her mother, her sisters, it's not going to be intrauterine malnutrition. I don't think it's insulin resistance. She's also young, you know. What? Oh. What? The ultimate cause of weight gain is energy intake and excessive expenditure for the majority of patients. Yeah, I know. That's kind of like, but I thought it's kind of a genetic thing. I don't know. Fine. You're trying to trick me. 24-year-old man presented to his GP with a nodular rash over his shins, which was dusky blue in appearance at first but had later faded to a bruise-like appearance. His past history included intermittent diarrhea with blood, no other past history of note. On exam, there was minor tenderness on the left side of his abdomen, and proctoscopy demonstrated moderate inflammation of the rectum. Blood test results revealed a raised CRP and a normochromic anemia. What is the diagnosis? I'm going to say, it's ulcerative colitis. Yes. And the skin condition is, they didn't say what the skin condition is. Erythema nodosum. Perfect. So we need to treat this man who has hematemesis. He's been drinking several cans of cider. What's cider? What is that? Alcoholic beverage. Why would someone drink that? It looks weird. Anyways. On exam, he was deeply jaundiced but alert, with stigmata of chronic liver disease. Blood pressure was low, and after resuscitation it got high, and he was still vomiting. What did we give him? Sorry? We just resuscitated. We didn't give anything. What's the first thing to do in a guy who has acute hematemesis? Endoscopy, IV nitrates, IV somatostatin, IV terlipressin. Is it not? Yes. Yes, it is. So, most common cause of upper GI bleeding. I'm gonna say esophageal varices, but I don't know. It could be like, yeah. Oh no, it's not. Chronic peptic ulcer accounts for half of the cases. Wow. That's insane. Well, we need to look at the notes. Upper. Where are the causes, my love? Most commonly esophageal varices or peptic ulcer? Well, apparently peptic ulcer is the most common. I feel lied to right now. Let's kind of add that to my notes because it's important. Well, there's no place to add it to my notes, so. Upper GI bleeding, most common cause is peptic ulceration. Peptic. Variceal bleeding. To a 75-year-old nun presented to her GP with gradual abdominal swelling over some months and generalized abdominal tenderness, worse in her right flank. On exam, there was inguinal lymphadenopathy. Blood tests revealed normocytic normochromic anemia, decreased serum albumin, elevated creatinine. Her CA-125 was raised. What could this be? I wonder. Wait. Ovarian? Yeah. I mean, if you hadn't told me the tumor marker, I would be confused. But I would also like kind of consider it because of the inguinal lymphadenopathy, the old age, she's a nun, you know. There are a lot of risk factors, so yeah, that's an easy question. What is the mode of action of imatinib? Inhibition of tyrosine kinase. Yay! What else is it used for? It is used for acute chronic myeloid leukemia and gastrointestinal stromal tumors. Okay. Next, 74. He presents to the gastroenterology clinic for review. He does not think he has had a change in bowel habit, but has been feeling more tired recently. His past medical history of note includes early dementia, hypertension, for which he is treated with amlodipine and indapamide, and asthma, for which he is treated with low-dose seretide. On exam, his blood pressure is 142/72. His pulse is 72 minutes regular. His abdomen is soft and non-tender. There is a mobile, non-tender, firm mass in the right iliac fossa. Which of the following is the most likely diagnosis? Let's look at the labs. They're fine. He just has been feeling more tired, like that's it. And he has a mobile, non-tender, firm mass in the right iliac fossa. What could it be? Is it a right iliac fossa? Iliac fossa? No, that's not a hernia. Lipoma. Why not a seagull carcinoma? I mean, he has anemia. And he's been feeling tired. That's what I'm gonna choose. Okay, cute. You were asked to review 53-year-old diabetic. He has diarrhea. He's currently taking metformin at a total dose of 2 grams per day. The diarrhea appears to worsen with increased metformin dose. What's the most likely cause of his diarrhea? I'm gonna say osmotic or secretory. I'm going to go with secretory. What? Why? Okay, why is it not secretory? This occurs in response to endotoxin producing bacteria. For bile acid, bioguanide medications such as metformin are one cause of bile acid malabsorption. Bile salts cause diarrhea by reducing the absorption of water and electrolytes in the colon. That's okay, but why? How would wait a second. This is kind of confusing. First of all, let's go to the anti-diabetic section. So metformin causes GI upset diarrhea. Oh yeah, well yeah, but why? Why? Like what? Okay, let's go to Gemini. Even though I kind of started to hate it now. Why does metformin cause diarrhea? Bile acid malabsorption. Because it inhibits the apical sodium-dependent bile acid transporter in the terminal ileum, and this results in higher concentrations of bile salts reaching the colon. Okay, it's not secretory, it's not autonomic, it's not osmotic. Well, let's add that it's associated with bile acid malabsorption. She's a 29-year-old drug user, lethargy. He was not part of a needle exchange scheme. He states that he's had unprotected sex as a male escort. Examination was unremarkable. Liver enzyme testing revealed raised AST, ALT, bilirubin, and ALP. Suspected of having hepatitis C. Which of the following factors is most strongly suggestive of the diagnosis being hepatitis C? Shear needles. Blood-to-blood contact is the most important thing. But what is a needle exchange scheme? UK needle exchange program. It's very interesting. Okay, let's go back. 61, peptic ulcer. He's on omeprazole daily. He was admitted with an inferior non-STEMI. He received 2 stents. He started on aspirin and clopidogrel as a dual antiplatelet therapy, and we reviewed him 24 hours later. He's stable. And, okay, everything's fine. What's the most appropriate course of action for what? Like, what's the issue here, my love? I don't know. Add ranitidine. I guess for the management of his peptic ulcer and non-stemite together, the fact that he's on, oh, okay, he's on aspirin and clopidogrel. Oh, um, PPI. Wait, ranitidine. I feel stupid right now, but ranitidine is an H2 blocker and omeprazole is a proton pump inhibitor. Okay. I don't know. Should we increase the dose? Should we add an H2 blocker? I don't know. I'm just gonna increase the dose because I don't know what to do. Oh, that's wrong. It's important. Oh, yeah, I know it's important to be aware of the drug interaction between omeprazole and clopidogrel, which has been reported to reduce the antiplatelet effect. Oh, okay. But no significant interaction is seen between clopidogrel and lansoprazole. Well, that's very interesting and also very, very important. So let's go to clopidogrel. Don't give with PPI. What do you mean? Don't give with omeprazole is what I should say. So we should replace it with lansoprazole. Okay, good to know. Anyways, 28, weight loss, oily, diarrhea, malaise, folate and iron deficiency, mild hypocalcemia. Very suggestive of underlying celiac. Very suggestive, actually. 67, ischemic heart. He was stented. He takes a lot of drugs. He's tender in the epigastrium, which is most suggestive of an upper GI bleed in this patient. I would say it's the urea. Why? Because when there's an upper GI bleed, it gets kind of digested and the urea gets absorbed and it makes the urea in the blood higher. So we have a 32-year-old man. He has diarrhea, weight loss, and abnormal blood film. He tells you that he has suffered from diarrhea on and off for 3 years and is now presented as he has begun losing much more weight, 4 kilograms over the past 3 months. The loose stool is not associated with any blood or mucus. His last foreign travel was a year ago. Why are you telling me so many things? Again, he has diarrhea, weight loss, and abnormal blood. And he's begun to lose a lot of weight. There's no blood, there's no mucus. There's a mild pitting edema of both ankles. There's howl. Oh. Is this celiac? It's giving celiac. It's really giving celiac. I'm going to tell you why it's giving celiac. Because of the howl jowl bodies, because of the anemia. This is celiac, my love. Yep. Next. 45, Crohn's. He's itching now. He doesn't have an acute flare or anything, but he has lethargy and itching. He has some vague pain in the right upper quadrant. There's scratch marks and he has jaundiced sclera. What is associated with Crohn's? Something is associated with Crohn's. Now, what is it? I don't think it's ascending cholangitis. There's no fever mentioned. And the pain is vague pain in the right upper quadrant, so I don't think it's drug induced. There's no mention of a drug. I think it's some sort of autoimmune disease that's associated with Crohn's. And I think it's going to be primary biliary. I hope it's primary biliary cholangitis because I'm going to lose my mind. It's not. Yeah, okay, Samina. So, listen. It doesn't have to be ulcerative colitis that's associated with PSC. It could also be Crohn, you know? So you should be open to the possibility. Hmm. Also, it's a man. It's a man and who's an IBD. Why would you pick PBC? That doesn't make sense. 21-year-old student returned from summer travel in the Far East, presented with acute onset bloody diarrhea. She had a raised red rash on her shins. She described 2 previous attacks of acute bloody diarrhea in the past 2 years that resolved over a period of a few weeks. Her hemoglobin is low. Her white cell count is high. Her platelets are fine. Let's look at the treatment plan. Acute onset bloody diarrhea and a raised red rash. Acute onset bloody diarrhea and a raised red rash. And she came from abroad. I think this is really giving ulcerative colitis. This is what I'm going to choose. This is an acute colitis. The major differential is between infective or IBD. There are clues given that the ulcerative colitis is the case because of the rash, because of, you know. So we're going to do a plain abdominal to rule out toxic megacolon. We're going to do a stool culture to rule out infective causes. We're going to do a sigmoidoscopy to confirm the type of colitis and assess the severity, but caution should be taken in acute flares. And we're going to give her an IV corticosteroids to manage her acute severe colitis. 43-year-old lady. She has chronic liver disease and secondary to autoimmune hepatitis. She has hematemesis and melena, bleeding varices that are banded, and portal hypertensive gastropathies. She's jaundiced. She has a lot of things. What's an indication for TIPS? I don't think it's this. I don't think it's this. I think it's refractory or encephalopathy. I'm gonna pick this. Yeah. Only refractory ascites is an indication. Actually, TIPS can worsen or precipitate or worsen encephalopathy, so it would be crazy if I had picked it. Most suggestive of an upper GI bleed. Sorry, I just didn't I didn't even read the question, but yeah. 62. She came complaining of problems swallowing liquids and solids over the past few months. She said that this was associated with retrosternal chest pain and that she tended to regurgitate both liquids and solids. She has gradual weight loss. Otherwise, she felt well and had no significant past medical history. She looked well. Her blood pressure is high. She had no lymphadenopathy. Abdominal exam was normal. BMI was 27. Hemoglobin. She has a bird's beak. Come on. Let's just don't waste my time. Bloody diarrhea and weight loss. What would favor Crohn's? I'm pretty sure that crypt abscess is not it. Superficial ulceration is also not it. I forgot which one causes transmural and which one causes inflammation, but I'm pretty sure that Crohn's causes transmural inflammation, but it also causes skip lesions. So I'm gonna say patchy. Yeah. Transmural skip lesions. Crypt abscess would be in ulcerative colitis. Crypt distortion also. Inflammatory infiltrates are found in both. Superficial ulceration is incorrect. Dyspepsia. Not a risk factor for gastric adenocarcinoma. Sorry, what? Why do I just want to choose H. pylori? It's just giving. It's not giving gastric adenocarcinoma. It's giving um, gastric maltoma. Should I pick it? Oh, it's a risk factor. Aspirin reduces the risk of carcinoma by inhibition of COX and other malignancy related pathways. The risk factor for gastric cancer include Helicobacter pylori, low dietary vitamin C, family history, high dietary salt, racial origin, gastric surgery, pernicious anemia, smoking. Okay. 37-year-old man who is known to have ulcerative colitis is admitted with severe disease. He's opening his bowel a lot of times. What is at day 3? Which of the following features is most associated with progression to colectomy? Colon diameter. Colon diameter is 5.5, not 4. Stool frequency more than 8 per day is associated with progression to surgery. Is this in the ulcerative colitis video?
I'm Dr. Baines, and today I'm going to talk about ulcerative colitis. Ulcerative colitis consists of inflammation and ulcers that start at the rectum and do not go beyond the ileocecal valve. It is thought that there are immune factors that trigger ulcerative colitis, as well as there being a genetic component, and also environmental stresses, such as smoking, non-steroidal anti-inflammatory drugs, and potentially antibiotics as well. Risk factors for ulcerative colitis are ethnicity. Ulcerative colitis can occur in any ethnicity, but Caucasians have a higher degree of risk. Furthermore, if there is a family history of ulcerative colitis in a first-degree relative, the patient is at increased risk. Patients can present in a similar way to Crohn's, except they're more likely to have bloody diarrhea in ulcerative colitis. Patients may also report tenesmus, as well as significant abdominal pain in the left iliac fossa. Weight loss may also be a component if they have poorly controlled disease. Extraintestinal features are also similar to Crohn's and include skin lesions, eye involvement, joint pains, but perhaps most prominently, primary sclerosing cholangitis. The major complication in ulcerative colitis is colorectal cancer. Colorectal cancer is much more common in ulcerative colitis than in Crohn's disease. Blood tests can be helpful in ulcerative colitis, both for assessing nutritional deficiencies but also assessing disease activity. In ulcerative colitis, the CRP tends to correlate well to disease activity. When looking at pathology, unlike Crohn's, there are no skip lesions and the inflammation is continuous in ulcerative colitis. Endoscopically, one may see pseudopolyps, but more prominently raw mucosa which can bleed easily. On colonic biopsies, submucosal inflammation may be visible. Inflammatory cell infiltrate is seen in the lamina propria. They may also be reduced goblet cells and mucin. Crypt abscesses are also formed by migratory neutrophils. Imaging does not add too much to the diagnosis, but abdominal X-ray can show a lead pipe colon or thumbprinting in active disease. Management of ulcerative colitis depends on the severity of symptoms. This can be assessed using the Truelove and Witt criteria. In severe cases, with more than 6 bloody motions a day and fever, for example, admission and IV steroids are indicated. In these cases, if steroids do not induce remission, rescue therapy with biologics may be indicated in order to try to prevent colectomy. Once the acute flare has been adequately controlled, maintenance therapy needs to be initiated. In simple cases, this can be azathioprine, mercaptopurine, or less frequently methotrexate. Maintenance therapy should be initiated in any patient who has had a severe flare or more than 2 flares in a year. If the patient does not tolerate these immunomodulators, for example due to side effects such as pancreatitis or agranulocytosis, or they fail to control the disease, treatment should be escalated to biologic therapy. Managing colorectal cancer risk is essential in ulcerative colitis. Factors that increase risk of colorectal cancer include onset of ulcerative colitis before the age of 15, a disease duration of more than 10 years, pancolitis, and unremitting disease. For patients who are low risk, i.e. have ulcerative colitis.
I mean, I know that severity is associated, or it's determined by the amount of times the patient passes stool per day. So I guess this kind of makes sense. Also, the colon diameter is More than 4 is not, I guess, mega enough. So we have a 17-year-old, and she's been inpatient. She ingested a lot of paracetamol tablets. What would qualify her to be listed for a super urgent liver transplant? Okay, you're asking me, you're really asking me about this. King's criteria. King's criteria. I mean, I have studied this before, so I don't know why I made this mistake. Rule of 3, pH 7.3, PT more than 100, creatinine more than 300, grade 3 or 4 encephalopathy. APCM. A PCM overdose, a paracetamol overdose, acidosis less than 7.3. Bilirubin more than. Bilirubin is not even in here. Prothrombin more than 100. Creatinine more than 300. Oh, 300 is it? Yep, 300. Okay. Oh my god. 34. Type 1 diabetes. She's tired. She has itching. Her bilirubin's high. Her ALP is high. Her AST is high. Her ALT is high. Her ESR is high. And we want to confirm the underlying diagnosis. How would we confirm it? Let's see what pattern does she has. She has I'm gonna say she has an I'm gonna do an anti-smooth muscle antibody. Yeah. Okay. 37. He has severe epigastric pain that was becoming increasingly constant. A screening test for H. pylori was positive. Which condition is most strongly associated with this infection? What's this? $56. Abdominal pain, diarrhea with heartburn, lost 2 kilograms of weight. He is concerned that he has cancer. He has a multiple gastroduodenal ulcers. Also, he has vitamin B12 deficiency. He drinks 2 units of alcohol per week, so I don't think this is chronic alcohol abuse. Also, they haven't given me a liver function tests. But I mean, the only positive things are the pain, diarrhea, and heartburn. Multiple gastroduodenal ulcers. Why would he have that? Is it H. pylori, you think? Why would he have diarrhea? Zollinger Ellison? Maybe. Yeah, I mean, why else would he have multiple ulcers? Increased gastric acids also inhibits vitamin B12. Carcinoid syndrome. Diarrhea. Site of amino acid absorption. Duodenum. Oh, so it's not. They're talking about absorption, not digestion. So, in the duodenum, they are degraded by pancreatic proteases, but absorption happens in the duodenum. And that makes a lot of sense. This is such an easy question. Diagnosis: acute severe pain in the upper abdomen. Smokes a lot. 1 pack per day. He has indigestion. He woke up from sleep and he's been in agony ever since. Cocodamol has not helped. His abdomen is extremely tender and rigid. And he has a high white cell count and a high creatinine and a high amylase and a high ALT. What is the most likely diagnosis? I have a feeling it's pancreatitis. Does he have a fever? Perforated duodenal ulcer? Maybe. Yeah, that's what it is. Mm. We have a 72-year-old man. He has type 2 diabetes. He comes with severe abdominal pain mixed with dark blood. He reports paroxysms of lower abdominal pain occurring after meals. On exam, his temperature is high, his standard, acidosis, ischemic colitis. What is the most likely affected area? Splenic flexure, watershed. 24-year-old woman. She presents as an emergency to her general practitioner with acute vomiting. Her symptoms began 3 to 4 hours after attending an afternoon meeting. Cream cakes were served during the tea break. Most likely cause of the attack. They said cream cakes, so a staff. Even though I really wanted to say something else, but okay, I'm going to tell you a secret that will help me go through the rest of the questions. So we have around 50 questions left. Yeah, 51. So let's do one more and then I'm going to do my trick. Elevation of which of the following components of the lipid profile is likely? Oh, I did this question before actually. It's chylomicrons. That's crazy. Okay, I'm gonna end the session and then I'm gonna do a trick. And the trick is going to be that I'm going to divide the questions so they seem like smaller bits. Wait, let me see how strong I am in the GIT now. Not enough. So let's do gastroenterology, and then we're going to do the average ones first, for the questions that I have never seen. So we have 30 average questions, and we're going to have 20 easy questions. So let's do the 30 average questions. 38-year-old farmer comes to the clinic for a review. He's been referred with dull right upper quadrant abdominal pain, intermittent night sweats, and gradual weight loss over the past 6 months. He takes no regular medications and farms both sheep and Arab. His blood pressure, blah, 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 1 centimeter liver edge. Diagnosis. Oh. It could also be hydatid disease, you know? Does he have diarrhea? No, this is hydatid disease. 20-year history of ulcerative colitis. He was lost to follow up. He was reviewed. He had a change in bowel habit for 3 months. Diarrhea increased up to 3 to 4 times per day. Most appropriate next step. I mean, you didn't tell me what he's on right now. You didn't tell me what labs he's done. So this question is very exam style right now. It's giving exam. He's just reviewed. He doesn't even have an acute attack. Oh my god, this question's so annoying. I'm gonna do a plain abdominal x-ray. Oh my god. There is a stepwise increased risk of colonic adenocarcinoma that starts 7 to 10 years after the onset. So, a new change in bowel habit should always be investigated. Okay, fine. He's assessed in hepatology. He's diagnosed with cirrhosis, and he has hemochromatosis as well. Which of the following underlies the pathophysiology? Decreased plasma hepcidin. That's exactly what happens. So we need to diagnose this 72-year-old man. He has indigestion and regurgitation. He has a feeling of fullness and retrosternal pain. He has dysphagia to both. His weight is stable. He has obesity as well. And diagnosis. Why is it not a pharyngeal pouch? No, wait, he has dysphagia to solids and liquids. And why does he have retrosternal pain? And why is it not an esophageal carcinoma? His BMI is fine and he's obese. I don't think it's a carcinoma. Benign esophageal stricture or pharyngeal pouch? I'm gonna say pharyngeal pouch. Oh my god, why? This is weird because yeah, you didn't convince me that the answer is not pharyngeal pouch. It's insane that not a lot of people pick this. 35, epilepsy, phenytoin, flucloxacillin, alcohol, paracetamol. So he's a 35-year-old man and he's on a lot of drugs. Now he has jaundice and markedly raised bilirubin and ALP. His gamma GT is also raised. So he has a cholestatic pattern. Which drug has caused this stuff? Gallstones? No. I mean, maybe, but I don't think it is. I'm gonna say phenytoin, but I'm not sure. You know what? I have nothing to say anymore, so I'm just going to not speak. Management plan. That makes sense, actually. I don't know why I picked that. Um, they're asking me about site of obstruction. For what? This woman is tender in her epigastrium. She has a right upper quadrant. She has high ALT, high ALP, high bilirubin, high a little bit of a high amylase. What's the site of obstruction? Is it the common bile duct? Is it the cystic duct? Is it the hepatic duct? I don't know. What should I say? Hepatic duct? Hepatic duct? Cystic duct? Bile duct? Is it before or after the gallbladder? Is it cholestatic jaundice? Yeah. Cholestatic. No, it's cholangitis. Cholangitis. I don't know why I'm picking this. Now that I've picked it, let me look at. Yeah. The key to solving this question is the fact that both liver enzymes and amylase are elevated. This suggests that any obstruction has occurred after the pancreatic duct joins the common bile duct, in other words, the distal portion. That's very interesting. This is such an amazing question. So we have a 52-year-old woman. She presents complaining of tiredness and itching. She had no history of alcohol excess. She's taken no medication. She has xanthal asthma. Her GP noticed that her ALP level was raised and she was referred for a gastroenterological opinion. What would confirm the diagnosis? This is PBC. Why? Because of the. I'm too tired to say why. So. Fever, cough, pleuritic chest pain. Now he has bulky stools and diarrhea. Huh? And arthralgia. Malodorous diarrhea. So he has some sort of malabsorption syndrome. He's 41. I'm going to small bowel barium follow through, HIV, chest X-ray. Is this? What is this? Whipple's disease. It's an uncommon illness that occurs most frequently in men aged 30 to 60. Malabsorptive diarrhea, Small bowel follow through may be useful for assessing or ruling out other causes of diarrhea. Diagnosis is confirmed. But why does he have cough and pleuritic chest pain? Interesting. 63, he has a 1 stone weight loss and he's anemic and he has a raised ALT and AST. Greatest risk of developing hepatocellular carcinoma. Why do I have a feeling it's going to be hepatitis E? Let me check my notes very quickly. Is it alpha 1 antitrypsin? Well, it causes fulminant hepatitis, but not cancer. So I really don't know why I'm picking this. Just because the rest are not giving. Hereditary hemochromatosis, so primary, not secondary. Long-standing ulcerative colitis, abnormal liver enzymes, and weight loss. Diagnosis: abnormal liver enzymes, weight loss. Cancer? Yeah. Because cholangiocarcinoma is associated with PSC and not PBC. Most suggestive of a diagnosis of ongoing hepatitis. Why am I going to choose this? I don't really know. Oh. Pruritus is associated with cholestatic liver disease. Positive smooth muscle antibodies is an O2. Well, yeah. I don't know why I didn't pick that. I just thought that. I don't know what I thought really. Okay. 78 gastric ulcer, lowest risk. What's a peroxicam? Celecoxib is safe. Is the safest. I don't know why. I feel like I've done this question before and I've gotten it wrong. So coxibs have less effect on gastric ulcer. Treatment for HCV. I'm gonna pick this. Emtricitabine and tenofovir are for chronic hep B. So this is something really interesting I read here is that first of all, what you would do is you do tests to establish which genotype of the infection he has and what degree of liver disease he has. And then you would do a hepatitis C RNA level, and this will help distinguish if he is one of the small number of people who spontaneously clear hep C who will have undetectable hepatitis C RNA, as opposed to the larger number of people who will develop chronic infection and who will need treatment. Okay. Halfway through. 32-year-old Asian man spent a significant period of time working away in India. Returns to the UK complaining of chronic abdominal pain, anorexia, weight loss, and diarrhea. He is usually completely well, his only past medical history of note being asthma and hypertension. His BMI is 21, he looks thin. He has vague abdominal tenderness. Small bowel biopsy showed significant eosinophilic infiltration into the lamina propria. No organism, no bacteria, no ova, no cysts. What is that? Why did I pick that? Why? Onchocerciasis causes severe pruritus and blindness. Xenophilic gastroenteritis is common in Indian and Northeast Asian, and does he have atopy? He has asthma. Oh my god. I don't know why, but I need to force myself to study eosinophilic gastroenteritis before I sleep so that I don't regret this. Let me open it. Known to drink alcohol, comes for review. He has severe epigastric pain radiating to his back that has increased in severity over the past 6 weeks. Why didn't he give me his amylase? That's so annoying. I feel like this guy has obstructive jaundice, and then that is complicated with acute pancreatitis. So, no. How old is he? Could it? I don't know. Underlying pancreatic carcinoma. Yeah. Best describes hepatorenal syndrome. Almost all patients have ascites and are usually jaundiced. Complete recovery is expected. E. coli is often present. It's due to glomerulonephritis, associated liver disease. Marked proteinuria is the hallmark. Let me revise what I know about this disease. What I know is that what happens is that there's cirrhosis, and then there's portal hypertension, and then there is increased splanchnic vasodilation, and which decreases arterial blood flow and causes renal vasoconstriction and decreased GFR. I'm gonna say yeah, that is more proteinuria. Wrong. Why did I say proteinuria? I don't know. Liver disease is severe in almost all patients of ascites. The hallmark is oliguria and progressive decline in renal function. Okay. 72 had HCC, most significant feature in the epidemiology of this condition. Why do I want to pick none of them? I don't think that 80% are surgically resectable. I think a lot less are primary biliary cholangitis associated with high incidence. I don't think that's true. The highest incidence of this condition in the world is in Europe. Maybe. Why not? Most common etiological factors: alcohol-related cirrhosis. I think it's hepatitis C. The risk of hepatocellular carcinoma is increased in patients with chronic hepatitis B who are E antigen positive. That's a marker of infectivity. It's not a marker of. Oh my god. It's in East Africa. Okay, and Southeast Asia. Yeah, that makes sense. Okay. Fine. Diagnostic test for new onset dysphagia. That started off as liquids and then 2 months later to solid. Why? Yeah, that's what I meant. Barium swallow. What's a barium follow through? Anyways, the history described is the classic one for achalasia. Why do I need a barium follow through? That makes no sense. Esophageal pull through manometry makes more sense, yes. Diagnosis. What? How would a SIBO be treated? I guess it's metronidazole. Oh, It's rifamycin, metronidazole, and carboxyl. Yes. She's in the 3rd trimester and she has jaundice. What is this? It's not HELP syndrome because there's no low platelet. It's not. I'm gonna say it's acute fatty liver pregnancy because that's the one that occurs later on in the pregnancy. 28, African. Bloating, intermittent diarrhea. She eats a European style diet. Next management. What's the issue here? She's African? Okay. And she has abdominal tenderness, bloating, and diarrhea. Lactose intolerance. Um, 35-year-old office worker, 5-month history of intermittent right-sided abdominal pain, watery, vomiting, weight loss, clubbing, right-sided tenderness, high CRP. It's Crohn's. Large bowel because it's watery. Sorry, what? The absence of features of colonic disease implied that there is no large bowel involvement. So? Oh, I picked large bowel. There is no bleeding. That's why it's not large bowel. Finger clubbing is a well-recognized feature of small bowel Crohn. That's so cute and interesting. A liver biopsy is required to distinguish between alcoholic and non-alcoholic. I don't think so. An ALT to AST ratio more than 2 suggests that NAFLD is more likely. An ALT to AST ratio more than 2 suggests that alcoholic liver disease is more likely. An abdominal ultrasound would be able to differentiate. A raised gamma GT would confirm that this was alcoholic. I don't know. I'm gonna say it's this. But yeah. Okay, 5 more questions to get correctly. He is a bar owner. He's having problems sexually. He's drinking a lot. He looks tanned. He has hemochromatosis. Initial screening test is transferrin saturation. Oh, no. 4 more questions to get correct. 42-year-old woman. She has one. She has 1.5 bottles of wine per day. Is that a lot? How big is a bottle of wine? Well, her GP is concerned because of a rise in her transaminases that he has documented over the past few months. Her medical history includes hypertension. She has been consuming half a bottle of wine every day since her divorce some 5 years earlier. Examination reveals a blood pressure of 152/90 with a pulse of 85 and regular. Her BMI is 34. Hemoglobin's low. Platelets low. I'm sorry, what's the issue? Oh. Because it's enlarged. With steatosis. That's what I meant. That's sad. Okay, most likely level of obstruction. What is this? Gallstone disease. Tender and jaundiced. Cobalect. Why? You just told me that a distal common bile duct lesion would result in elevated amylase. This is crazy. I mean, it's heavily elevated. Yeah. Okay. Absolute contraindication to liver transplantation. No. 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 Mm. Contraindication. Why? It's the only effective treatment for primary sclerosing cholangitis. Absolute contraindications to liver transplantation include untreated HIV, severe irreversible pulmonary disease, ongoing alcohol abuse, and extrahepatic malignancy. Cause of his symptoms: loss of libido. Three liters of Diet Cola, that's crazy. And why does he have bilateral hip pain on flexion? I'm really confused right now. Hemochromatosis. Okay, I just got 50%. That's so sad. Let's do the final session. Basically all of it. diarrhea, abdominal pain, flushing, flushed face, appropriate investigation, urinary 5-HIAE. Because it's carcinoid. Atrial fibrillation, cardiovascular disease, acute abdominal pain and vomiting, drowsy and unwell. He's an AFib, he's hypotensive, he has a high amylase, neutrophilia, kidney disease, high creatinine, high urea. He has intermittent lower abdominal pain and diarrhea after dinner over the past few months. What's the diagnosis? Acute and chronic mesenteric ischemia? Maybe. His amylase is elevated, so that's also making me a little bit confused. Wait, would atrial fibrillation cause mesenteric ischemia? Should I just pick acute and chronic mesenteric ischemia because that's what I feel like they want me to pick? Okay. Is a cause of elevated serum amylase that's unrelated to pancreatitis? Okay. Next. 62. Diarrhea, weight loss, abdominal pain, malaise, fever, oral ulcers, red itchy eyes, tender nodules on her chin. Vague right iliac fossa mass. What is this? What? Why? Terminal ileitis. Oh, episcleritis. Huh. This is weird, but I don't care anymore. It's not this, it's not this. He went on to have a gastroscopy. Oh. Come on, I really want to finish this. It's almost 2 a.m. He has a couple of episodes of hematemesis. He's poorly compliant on his propranolol. He has a lot of stuff. Next step. Appendectomy, distended abdomen. Generalized tenderness, no features of peritonism and tinkling. Imaging investigation, so it's not expiratory surgery for sure, and it's not CRP. Ultrasound, X-ray, CT with contrast. I feel like we would do an ultrasound right away. Initial, I mean. Sensitivity is low. If we're suspecting bowel obstruction, we do a CD with contrast. That's very interesting. Wow. That's completely unlike anything we do in our hospital. We never do this. We would do an x-ray actually. Like, I don't know why I picked ultrasound. Anyways. Confused. High ALT, bilirubin, ALP. Oh. It's not gallstones. It's not carcinoma. Salmonella. It's not salmonella. It's hepatitis A. Which drug causes bile acid malabsorption? Oh, it's metformin. I just may. Thank you. Come on, don't waste my time. 6 weeks after a laparoscopic cholecystectomy, and what's the most likely diagnosis in this case? What would it be? Bile acid diarrhea, IBS, pseudomembranous colitis. It could be pseudomembranous colitis, but the diarrhea is. Okay. Bacterial overgrowth. I'm just gonna pick this. Yeah. It's a well-recognized feature of the post-cholecystectomy syndrome. One-year history of intermittent difficulty while swallowing and halitosis. Fullness in his neck. Regurgitated undigested food. Diabetic. Currently taking metformin. Recurrent bout of pneumonia. Asthma. Diagnosed by his general practitioner. Diagnosis. This is really giving pharyngeal pouch. Supporting a diagnosis of a connective tissue disorder. Raynaud's. Come on. Oh my god. Test that can exclude celiac. Diagnostic test for celiac. Barrett's esophagus, 3 centimeter segment with biopsies revealing no dysplastic changes. He has heartburn and nocturnal cough. Yeah, that's what he should do. That's an easy question. Which of the following statements about achalasia is correct? Decreased risk of esophageal adeno? No. Difficulty in swallowing? No. Failure of relaxation? Yes. Oh my god, it's the last question. I can't believe it. Returned from a holiday in Morocco, intermittently confused. She suffered prolonged fever, myalgia, headache, and cough for some days. She also noticed some diarrhea after returning home. There were several faint rose spots which blanched on her chest, and blood tests revealed neutropenia. What a nice last question. So she went to Morocco. And then she had fever, myalgia, headache, and cough. And rose spots. Typhoid? I'm gonna say it's typhoid. Yep, it's typhoid. Okay, now I'm very curious to see my score. So let me go see it. It's 293 divided by 442. So 66%, I guess. Yeah, it's 66%. Okay.